Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways in medicine, clinical tips, and much more. If you have any questions or any ideas for guests you would like to see on the show, shoot us an email at podcast@medsoc.org.au. That's podcast@medsoc.org.au. I'm Sean.
And I'm Emily, and we will be your hosts. Today, we are very excited to have a chat with Dr. Kalli Spencer, who is an expert in the field of urology and has extensive clinical experience and research experience. He completed his undergraduate degree at the University of Vet in Johannesburg, South Africa. He has completed a Masters of Medicine in Urology and moved to Australia to complete a fellowship in oncology and robotic surgery at Macquarie University Hospital and at Westmead Public and Private Hospital. He currently works as a lecturer of clinically applied and surgical anatomy and is a senior lecturer and co-convener of clinical skills at UNSW. Welcome, Dr. Spencer. How are you?
I'm good, thank you. Thanks for having me on your podcast. I just wanted to make a correction. Most people get it wrong. The university where I studied, it's got sort of a Dutch name, so that's why it's hard to pronounce. But it's Witwatersrand. Yeah, the University of Witwatersrand in Johannesburg.
What a cool name.
Yeah.
There's no way any of us would be able to pronounce it fully
Apologies,
correctly.
I butchered it.
Yeah, all right.
So would you mind telling us about what it was actually like going to medical school in South Africa?
Yeah, it was a great experience. Probably the most memorable of my life, I would say. It was colourful. It was full on. I'm sure every medical school experience is full on, but it was full on in a different way, in terms of the spectrum of pathology that we got to see. We literally had anything you'd see in a textbook available in our wards at any given time. And that was because we had such a high patient load. And as for example, the one hospital where I did most of my training, both undergrad and postgraduate, was the Baragwanath Hospital, which is the largest hospital in the Southern Hemisphere with 3,500 beds. So you can imagine, busy place, and also a fairly poor population, low socioeconomic status, and sort of poor health literacy and knowing when to present to the hospital. So we often saw very late presentations of conditions. So cancers, that you would very rarely see in a first world setting, in the most advanced states, neck masses all the way out here. And, because they just didn't realize that they needed to go and get help, or they didn't have the means to get to the hospital. Or they were seeking spiritual or traditional healers' help first and delaying the presentation. So we got to see all of that. And so that was one thing. So the spectrum pathology available to us, but also the hands-on experience, because there weren't enough hands, doctors to help. So students got to do a lot of things. So very early on, in our undergraduate training, sort of right from third year, we could go into the hospitals and they allowed us to do things, cannulate. And then we did an elective also early on, and we were allowed to go to rural areas. And so in rural areas, they were even less resourced. And so there we got to do procedural things, like bone marrow aspirates and trephine, or putting in a chest drain even. So early on. So, it was a great experience. It also a very rich experience in terms of the culture, very multicultural society that we had, 11 different official languages. So it was very often hard to get an interpreter, especially after hours, even within hours. And so we had to rely heavily on our hands and our clinical skills and examination. Sometimes history wasn't available. And so you had to be good at examination and eliciting signs. That made it quite a unique experience.
Yeah, would you recommend this be the way we kind of teach medicine within Australia as well? Because it seems as though it's almost as if, because it's a low resource setting, there's a lot of opportunities for people who are quite early on in their training to start to begin and do procedures that in Australia only very advanced trainees or people very, very far into medical school would have access to even attempt. do you think there's a certain merit in, I guess, almost relaxing the pressure that we put on students a little bit and giving students who are a little bit younger in their journeys the opportunity to practice much earlier in their careers so that they have, I guess, a better accumulated experience as they go further through medical school?
Yeah, it's complex.
Yeah.
It depends.
Yeah, it definitely, it definitely depends.
Yeah, I don't think it's that straightforward. Firstly, we don't have the number. We have almost triple the population that in South Africa compared to what we have here. So there's a limited number of patients. I think we're well serviced in terms of doctors and specialists. So there isn't, and particularly in urban areas where all the training takes place. So there's a lot of competition to get hands on. Also, I think it's quite a litigious society. And so there's a big risk of putting really junior staff on and to do procedural skills so early in their career. So I think the requirement is to do a lot more simulation and observe practice before being able to do certain things with patients. So I think that's sort of the challenge. Yeah, or not, maybe the patients are more grateful, but certainly just to clarify, we would never just go and do procedures there either. It was always a case of observe, then do with supervision, and then do on your own, or the old dictum of see one, do one, teach one. Very much was something we would do. But in answer to your question, I don't think it's as straightforward. I mean, that would be the ideal for you to do it, but I think there's too many things or barriers or mechanisms in place that will allow you to do that.
Yeah, it seems as though there's a few things that kind of allow your university and hospital experience to be as effective as it was. And I think the way Australia set up the medical system is slightly different in good and bad ways. And I think it allowed you to have a lot more clinical experience very early on. But in like a society in like Australia where it's a little bit litigious, it's a little bit more safe, there's the students and also the patients benefit from a much better, higher and like more proficient level of healthcare across the medical experience as well.
Yes. It does seem counterintuitive though, doesn't it? You'd think if you wanted that to happen, the better care, you'd expect your doctors to have, or your students to have had more experience, so they can do that by the time they're qualified, but I guess that you catch up, or you do elective experiences elsewhere where you get that opportunity. But clearly it works, Yeah, 100%. But I can understand your frustration as students that you do want to jump in there and, get started and get to do these things and become proficient.
Yeah, 100%. I think one of the big things that I think our students get scared of is it feels like it's a very long time before we get the ability to do clinical exposure and have the hands-on experience. And we feel like, we're practicing on models all the time and it doesn't come close to the real thing. And I think that's one of the benefits of being having medical school in Australia, where there are ample resources for models for us to practice on, where I think when you went through university, you didn't have the models at all, and the models were just patients.
Correct.
Yeah.
You hit the nail on the head. Exactly that. We didn't have the funding to have all these, fancy simulators, but we didn't need to as well because we had the opportunity with the patients. So and
so it all balances out in the end.
Indeed. Yes.
As your time as a medical student and a doctor in South Africa, do you have any particularly interesting or crazy stories from your time there?
Gosh, wow. So many. How much time do we have? It was because of the amount of patients that we had to see, and because of the extreme presentations, and because we were under-resourced, you had to take on a lot of things as junior doctor, and so yes, we saw very sick patients, a lot of HIV, high infection rates. So memory, was just a patient with advanced HIV. and a bit of HIV/AIDS dementia. Sorry, and he was in his cot bed, but he wasn't fully in his cot bed. He had managed to escape through the narrow bars of the cot bed with his body, right? Yeah, because he was that thin. But his head obviously couldn't pass through as well. So my memory of arriving in the ward was seeing this patient who was naked, just standing sort of outside of his cot bed with his head stuck in the bed. I was like, oh boy. And the nurses, sort of called me.
Back into bed.
Well, what am I going to do for this patient exactly? So we had to get, the maintenance people out and try and get his head out of the cot bed. So that was an interesting story, an unexpected finding. Another time, the same patient had sort of gone out to the toilet and come back, and then actually climbed back into another patient's bed because, and fell asleep. And the other patient was obviously also so out of it that he didn't realize. So we just had two patients lying in the same bed. Because obviously his cot bed was up. Someone had put it up or whatever, so he couldn't get back in. So he thought, oh, well, I'll just park and share the bed with the other patient. So, wow, that's one story that sprung to mind. Another one was seeing it was an intern in the middle of the night, crazy long call. We used to admit maybe 30 patients in a 12-hour shift in the medicine intake ward.
Oh gosh.
Yeah.
That is a lot.
Yeah, and my record was having 60 patients I had to care for
At the same time?
Yeah, in the space of 5 days. I was responsible for 60 patients at one time. Yeah, you just sit there at night, doing ward work till 8, 9 o'clock at night. Yeah. Anyway, so the calls were also intense, and it was middle of the night, and this patient was quite in respiratory distress, and examination showed there was a lot of dullness on one side of his chest, and it was quite clearly an effusion. But we did an X-ray anyway, and we saw massive effusion, so we had to drain that. I had to drain it. So put in the chest drain, and this pus just came out, this yellow pus.
Oh,
and but it was like custard yellow. Sorry to ruin anyone's.
I will never have custard again.
I know. So and it's just coming out.
That's quite bright.
Yeah, it was a bright yellow, exactly.
Oh, wow.
And it's just coming out and draining, and I'm just watching the little chest drain bottle filling up. And then there's a hole at the top, which is open. And I'm like, no, that's not going to, come out of them. There's no way it will come out the top. And it's just going and going. The patient's coughing and the thing's just rising. And the next minute, the thing's coming out like a custard fountain. Or like a volcano. And I'm like, when you're that crazy tired and 3 a.m, you're just laughing, otherwise you'll cry, right? And I'm like, what is going on? What do I do now? I've never seen this before. So I run and I call a nurse, and they're like, yeah, this can happen. You just need to connect
from one patient.
Yeah,
it's a solid bag
from one into a bottle, a receiving bottle. It's just filling up. It must have been about 1.5 liters, right? And it's overflowing.
That's a lot.
And so she said, no, you need to connect another one. You can connect another one. So we quickly ran and connected the other one. But we had this whole bottle of this custard or pus.
Please call it pus more than custard.
The pus in the middle of the night on the floor. Yeah. Yeah, so that was just...
The fact that it was just standard hospital procedure. Yeah, don't you know that you should just connect a separate bottle?
How many times did that happen?
Never in my wildest dream would I expect that would overflow, but it did. Yeah, it never happened again, so...
And to that, I'm glad.
Me too.
So it sounds like you've had a lot of experiences as a doctor, but what made you choose urology?
Yeah, that's a good question, and not a straightforward answer. I suppose early on in your medical training, you kind of know if you're leaning towards medicine or surgery. And I'd say maybe the experience of seeing all these HIV-infected patients and TB and all the infectious diseases, I was like, I don't think that's for me, Also, I'm quite I like being hands-on. And, that's what appealed to me about surgery, is it's hands-on. Not that there aren't aspects of medicine or radiology, for example, that aren't, but what was also nice was a lot of the stuff you do is like instantly gratifying. You know, you can see a result, take out a tumor, and then that's it, you know, or laser a stone and, you know, it's gone, and the patient thanks you. Yeah. Well, they've got acute urinary retention, and you put in a catheter that no one else could put in, and you're like the hero. You know?
I think it's like, it's almost like you can. It's kind of like a problem-solving mindset. Whereas, like when you're doing like a surgery, it's like you go and it's like, this is the problem, and just fix the problem, and then you're like, it's done. Whereas like internal medicine is a little bit more of like a problem-solving
100%
kind of aspect, where it's like, oh, does this drug work? Does this drug work? And how do you titrate it and balance the things?
Exactly that. So you're relying on the medicine to do the work, right? You're not actually doing it.
Yeah. Oh, that's so well said.
Yeah. And there are exceptions in internal medicine, of course. You know, they do interventional things. But for the most part, yes, you're relying and you're adjusting dosages. And if it's not working, you're trying other ones, you know, and it's all of that. And I just want to get in and fix it.
Do it.
Yes, that was it. So this is part of the... So already I was heading the surgical route. And then I was like looking at general surgery and the lifestyle of the general surgeon. I thought, I don't know if that suits me so much, you know. And I also, be careful what I say. I was looking at the personality of the people working in there. You know, you got to see yourself working in that environment with those people, and you like those people, you know. And I just thought, no, and the lifestyle was another thing. And general surgery lifestyle is a busy one, and you know they're always at the hospital, and very often your patient is your responsibility, and even when you're not on call, often you have to come back in if there's any issues related to that patient and deal with them. Whereas with urology, we sort of tend to more hand over, and someone else from another team can even help.
Oh, truly get and solve the problem, and the rest is not my problem. The professional handover machine.
Not always, though. No. I mean, that sounds really... Yeah, no. I mean, you are responsible for your patient, and any complication you cause, you need to fix. Yes, always. So there's that. So lifestyle, definitely, and the urologists are always known as the happy surgeons. Well, that sounds good. But also, what I like was that it's also got a medical component to it. It's not only surgical. And you know, there's all the infertility, sexual health side of things, the endocrinology. So there's still medicine, all the BPH, a lot of medical management. Also like that there was a spectrum, so there's pediatric urology and adults. And a lot of people also think that urology is only about male patients when it's not. You know, there's all the urogynecological stuff, the incontinence and all of that. So it gives you a really good spread, you know, of different ages. It's exciting. But one of the other things for me, what drew me in was that it covered a lot about men's health and men's sexual health and the men's cancers. And I thought there was such a need for that. It's really not spoken a lot about, and it's not, you know, there's more that could be done. And I'm, as you'll hear later, quite interested in advocacy, and so I saw it as a gap, and something I could, you know, really step into. And the other thing that's not covered well traditionally in our training is sexual health and sexual medicine, and that was something I was quite interested in as well. So that's probably the longest answer anyone's given you as to why they chose a speciality. But that's about it in a nutshell.
Yeah, that does make sense. It's like, I think especially as medical students, we're very scared of asking about sex. It's just like, it feels really strange. It's like you talk to a patient, especially a patient that's older than you.
Yes.
And for most of our medical careers, we are the younger side. And you only really get to that kind of like experience when you're much further along, which is like the complete opposite way. Like we should live life backwards, to be honest. But it feels very strange to ask about sex, especially when like we're so young compared to the patient we're asking.
Correct. But I think it's like everything in medicine, you know, if the patients have come to you for help and they trust you, and if you're following all our empathic listening skills training that we're doing for you and learning to be good listeners, they will open up. You know, they will tell you, and you'll be surprised what they'll tell you. People are willing to be vulnerable, and so they will share that. You've just got to ask. And so you've got to know how to respond. It's really up to you if you don't get the training to know how to have those conversations, and also educate yourself about some of the common sexual health dysfunctions that are out there, and then you can have that conversation, and they'll appreciate you for it. But there's also many experienced doctors out there as well, who aren't as young as you that also don't have those conversations or are afraid to have them.
Yeah, one of the good things about, I guess, especially for us during medical school, when we have those times to go into clinics and go into hospitals, where in third year we're basically given free reign to go into hospitals whenever we like, whenever we have time. Essentially, we might not be able to do procedures all the time, but we will always have time and ability to just talk to patients. And practicing history is much more important than being able to do the most perfect cannula. So much so.
Yes, no, I mean, those procedural things are important, but you're right. Patients are going to remember you for how you spoke to them and your communication skills, because that's what they're going to say to their friends.
Yeah.
Oh, he was such a good doctor.
He was such a lovely doctor.
Yeah, he listened to me and he cared and he explained things to me and he told me what's wrong with me, and he asked about, how am I coping? They love that. That's what they want. But think of yourself, even if you went to a doctor and you were having a hard time in your life, you want someone that's going to be kind and caring and is going to listen to you. That's why you went into medicine in the first place, right? So, and that is an art. I agree with you, and it takes time to develop, and everything else will come later.
Yeah. Moving on, going on from that, I think there's a few people in the audience who might not be very, very familiar with what a urologist actually does. So could you tell us a little bit about what a day in the life kind of looks like for you, and why should we care about the things that you are doing on an everyday basis?
Yeah, we probably should have started there. What is urology?
What is a urology?
Anyway, now that you know about the lifestyle, and then just going back to the point about lifestyle, it really is attractive point, and it seems to be done all over, is we get to call from home. That's pretty big. So, you only rarely get called out if there's something serious. And there's a colleague of mine always used to say there's only 2 real urology emergencies, and one was a septic stone.
Yeah. Oh, okay.
So a patient that has a kidney stone, but not just any kidney stone, because many of them, but one where they really, urosepsis is quite bad, where they've got septic shock. And the other thing is like a case of Fournier's gangrene, which is a necrotizing fasciitis skin infection that can also make them very sick and can be life-threatening. Those are only there's 3. Because even I suppose the Fournier's gangrene can be treated, with supportive care. The other one, is actually testicular torsion. You've got those 6 hours, 4 hours actually, but 6 hours is really the cutoff. So that's the other true emergency. Those 2. Anyway, so going back to who we are and what we do. This is the other appealing part of the speciality. It's such a focused area you're dealing with. It's literally from diaphragm down to pubic symphysis.
It's one line.
Well, I mean, there's
other things. Yeah.
But I'm saying it's that area of the body. It's literally that. That's
forget about the head and the shoulders and the arms.
Oh, that's true. Yeah. They can be managed by other specialties.
Correct.
Internal medicine.
So that's all we have to deal about is that, And so that's what I thought. That seemed really appealing, that it's all there.
One small window.
Oh, yeah. But until you get into it and realize it's possibly the most complex anatomy, once you get into the pelvis and realize how close everything is and all those nerves and vessels and whatever, it's actually more complex than you think. But what do we do? So we look at kidneys, ureter, bladder. Some places, some urologists also do adrenal glands as well. And then bladder, and then in males, penis, prostate, and testes. So that's what we're responsible. Oh, and then of course in females, as I said earlier, incontinence are related to pelvic floor and prolapse. So within all of that, cancers, cancers of all those organs we mentioned, benign pathologies as well. And then stones, of course, in the urogenital system, and then the incontinence surgeries and prolapse repairs. So that's what we do in a nutshell. In terms of pediatrics, we also do like undescended testes and those sort of procedures.
What would you say is the most common surgery you do?
Yeah, that's a good question. Probably cystoscopies, so just looking in the bladder with camera and doing a biopsy. Prostate biopsies would probably be the other. And then surgery for benign prostatic hyperplasia, so doing TRPs, probably be and then stones.
Yeah, stones.
Kidney stones, ureteric stones, bladder stones. Yeah.
It sounds like you're very passionate about a lot of things in urology, but you've mentioned before that one of the things you're really passionate about is advocacy. Could you tell us about how and why you became involved in this?
Yeah, good question. Long story. How much time do we have? I suppose you know in your mind that you're a activist and you like to, if you see something wrong in the world, you like to make a change. And so I'd say, I mean, I could probably trace it way back, but probably where it all began is when I was involved with the Junior Doctors Association of South Africa. And so that's the trade union for doctors, much like yourselves, involved as students. I was also involved actually on the Medical Student Society at University of Witwatersrand, and involved there. We did do some projects and work. We used to have an art exhibition for med students. And we did a really good one on with an AIDS theme, which was quite good, and creating awareness. And I was also part of so it was arts and culture, so I brought lunchtime music concerts to the medical school, which was quite nice. So it was a pretty dreary, dull place. So I teamed up with the music faculty on the main campus and got their musical students to come and play. But I was also quite connected with the arts outside of university, and I got these beatboxing guys to come and perform.
That's so cool.
And this dance crew to do some break dancing just in the middle of lunchtime, and had a huge crowd, and like ever seen before. Anyway, I'm sidetracking. So I always was involved on committees. Even back in school, I was on the Junior City Council, and anyway, so that evolution continued, and so I joined the Junior Doctors Association, and then ultimately joined the Senior Doctors Association and became the chairperson for the state. But part of the role, the media were very interested in what we did and what we were doing outside of medicine as well, and teenage pregnancy was a problem in South Africa for many reasons related to socioeconomic circumstances. And they asked us, we had a whole awareness month, and they said, well, what are you doing? The media said they wanted to find out what we're doing as an association. I said, well, what are we doing about this actually? And I remember back to my internship, I was still in my internship, but when I did my obstetrics and gynae, we had all these really young patients coming in, and pregnant. And, they were reluctant to have vaginal examinations, one even pushed me on the floor once. They like literally kicked me on the floor when I needed to assess them, and sort of stuck in my mind. But the thing that stuck most in my mind was doing the abortions on these young patients, and I just thought this felt so unnecessary, But probably the catalyst was when I had a 17-year-old, so school student, who would get delivered a baby who had a congenital heart defect that was incompatible with life. And so we literally had to tell her that her baby wasn't going to make it. And so that stuck in my head, I thought this is really unfair. The high school student probably doesn't know where the heart is and what it works, and now we've got to tell her that there's something wrong with the baby's heart, and that's why your baby's not going to make it, And so all of this was going through my mind, and I thought, okay, you know what, we need to do something here. Maybe I should go into high schools and educate these high school students. And so that's what I did. It was a big school, about 700 or 800 students, stood up in their assembly time on the stage. The media came along, and it made the front page of the newspaper, like pregnancy tsunami, they call it as the headline.
That's a wild headline.
That is.
Right? I mean, you can't plan these things. You know, the journalist is going to do what they're going to do.
What does that even mean?
I know. So that drew a lot of attention, of course.
Oh yeah.
Yeah.
Sure would.
What does a pregnancy tsunami even mean?
I know. So people got there was a lot of interest, and one of the people that contacted me after that was an organization already doing this kind of work called Just One Teenager, and basically they were referring to if they could change the life of just one teenager, then they were already making a difference. And so they were going into schools. They were a midwife, nurse-led team, and they were going to schools and do this half-day workshop and educate these high school kids. And so they said, well, would you like to come along and give your doctor aspect? Actually, they had a doctor and he left, and so there was a place, and they said, well, would you be keen? I thought, well, yeah, this kind of makes sense. Maybe I can continue this work. So I teamed up with them and started going to these half-day workshops and talking to the high school kids about sexual education, telling them about pregnancy and telling them pregnancy is okay when it all goes all right. But when things go wrong, then it's not so okay. And are you equipped and ready to deal with that emotionally? And, how can you, who's going to support you? What support do you have? And so I did that. And then as I because of my position on the committee, I was sitting with deans of faculty of health sciences. And so they were quite powerful, and we could get other doctors on board to take a bit of time off from their clinical duties and help with running this program. And so it became sustainable because I couldn't go to every single workshop. And so I got more of them involved, and they were quite keen to do a bit of community and advocacy work themselves. And they went around, and I did carry on as well, and that was our program. So that's where it all started. That's the first part of my advocacy journey. Then I went on to do the beginning part of my urology training, sort of the PYG kind of years, pre-registrar training. And I thought an obvious thing was to work in urology or work something similar. And a big issue, as I mentioned earlier, was the HIV, high rate of HIV. And one of the things that was proven to be effective in reducing the transmission of the virus was male circumcision. And so there was a big push to have these medical male circumcision clinics around the country and throughout Africa, actually. And there was a lot of funding coming from WHO and UNAID from America. And so they were funding these clinics. And I had the opportunity to start my own clinic for medical male circumcision. So I set it up from the ground up, got all the nursing staff, went for training, and started doing circumcisions. I did like over 1,500 circumcisions.
Wow.
Yeah.
That needs to be a stat. Oh my
I know. And it was an amazing experience because I also had to promote the service. And so I'd go out, I could do radio, I'd do TV, went everywhere promoting this, went out into the communities, went into public transport, commuter areas, and just spoke. We had, and then eventually even linked up with big organizations like Movember, and we'd go out and do these drives to promote all of this. But it was also the benefits. But what was also good was the opportunity I had when we had these young male patients who would probably never go to a hospital otherwise, unless something happened or they got sick. We had an opportunity to talk to them about preventative health and health promotion. And about safe sex, and about all the other aspects, of HIV, and then the cancers and large prostates, and because it was all done under local anesthetic. Where we're doing the circumcision we couldn't anesthetize so many people, so I would do.
You would just be doing the circumcision, having a chat.
Yeah, while we were doing it. Yeah, and
just don't look down.
Well, we'd have a screen so they couldn't see.
Yeah.
So
that's reassuring.
Yeah, but we had like a row of like 7 or 8 patients at a time.
And just bash local anesthetic.
It was literally like it's just a joke, like a sausage factory. It was like literally a chain.
Just too much food today.
Too many food analogies. We're good at that in medicine. So there's just a row of patients. And what would happen is, well, we would, as doctors, I trained up interns and other junior doctors and med students as well. Med students got to practice their suturing.
Yes.
Yeah. So it was a great learning experience for us all. But anyway, we would do the first part, the frenuloplasty and the anchor stitches, and then the nurses would take over and finish the rest, or the med students, whoever else could suture, and we'd move along. So it was us like 5 minutes or whatever, and doing that bit and talking to the patient, and then move to the next and the next and the next. And the nurse would anaesthetize obviously first, clean, sterilized field and all of that. Then I would come in, do my bit, and then I would move on, and they'd finish, wrap, dress it up, and whatever, and move on. And so we'd go. And once I remember we did, working in a team like that, 2 or 3 doctors, about 7 or 8 nurses in the morning from 9 till like 1, we'd do 120 circumcisions.
Wow.
Yeah. Just go. Yeah. Yeah.
That's such a, not the conveyor belt I thought I'd hear today.
Yeah, so, and you become really good at it. And that was a great...
Oh, yeah, for sure.
You do.
That is how you learn suturing.
Right. And surgery and surgical skills and, cauterizing. Also, a lot of pathology came out of it, seeing hypospadias and, all and different conditions, benign pearly papules, benign things, and warts and STIs, so like lots of things came through. So it was really interesting. Anyway, I digress. And so the other thing I did was team up with Prostate Cancer Foundation in South Africa, and we'd go out and do screening. So we do blood tests out in the community, even DREs. Even once we were in a church, we had a screen, and there was an area where they'd have the DRE, and then they'd have their PSA. And we'd know immediately what was going on. So we did screen.
What is a DRE?
Rectal exam.
Oh,
digital rectal exam. Digital rectal exam. Yeah, and so I did that.
DR in the church is crazy.
Yeah, right. So extreme, interesting conditions, but yeah, a colourful experience. And then
colourful is not the right word.
Considering the conversation from earlier. So moving on, then I moved across to here, and my advocacy didn't end. I think once it's in your blood, you can't get rid of it. If you want to help, you help, and where you find a need, you jump in and you do. And so I always have. And so there was a need for bladder cancer support group or charity even. Didn't really exist. Or there were smaller ones not doing much. And so the urologist that I worked with when I moved here, this was at Macquarie University Hospital, said that a patient had passed, and she was quite keen before she said there was no support when she was on her deathbed, and she was in her 40s, 2 young kids at home. And she said there's no support, and she would love to see something happen. And so when she passed, her husband carried on her dream and a wish, and said, can we create a group and a website and an organization? And so we did. I teamed up with him and 1 or 2 other patients, survivors, and the urologist, and we started Beat Bladder Cancer Australia. And then we started face-to-face support groups at the hospital. And then I did training. I did a diploma in professional counselling. I did Cancer Council official training. And so I learned how to lead a support group and deal with all the aspects of support that were needed. Anyway, COVID came along, and we were all forced.
We love COVID.
Yeah, right. There were actually many benefits despite all the bad things that happened. There were actually some good things that came out of it. And one of those for us was that we got to do these support groups online. And so instead of having just one local face-to-face group, we could now expand it nationally. And so we did.
This is such an aside, but I often wonder how much COVID completely catalyzed the digital revolution in terms of like Zoom, everything being online, and for it to be okay. to be online? Because I remember
Correct.
before COVID, we were all like, no, there's no way you can do classes online. That would be
Yes.
like, that would completely destroy the dynamic of the classroom. And then as soon as COVID happened and it became a necessity, it's just so interesting to see how quickly we switched into going like, oh, this is completely fine. And from that, we get such a great, like, so much better technologies and so much better purpose-built technologies for being able to share content online, and it's just drastically increased the efficiency by which we can deliver care and provide the support groups on an online kind of format.
100%. The thing is that we've got a whole demographic of older people that were very resistant to technology, that would never have ever touched any of this, that were now going online. They had to, because they had to speak to their
It was
families
the only
they
option,
were cut
yeah,
off
yeah.
from. So they had to learn how to use it, and they did. And so what that meant was now they could use it for these other reasons in their life. And they did. They embraced it. It's quite unbelievable to see. You know, bladder cancer affects older people, usually over 65. So yes, we do have a lot of younger patients, but most of them are older people. And they come on and they can use the technology. And so that's great. And like you said before, we wouldn't have done this before. There's confidentiality issues, and there's, you know, all the verbal and
So much red tape.
Yeah, there's that, but also the verbal, non-verbal cues and communication, and who's listening in the background, and you know, and if they break down, you know, how will you console them, you know, while they so there's all of that, but we worked around it. We made it work. We had to. We all knew for people to get the support they required, we had to make this work, and so we did. And so we went from like 10 people to now getting 40 people a month in our support groups from all over Australia, every state and territory, and New Zealand. And recently we have 2 or 3 people that joined from America.
Oh, wow.
Going
You've gone
international.
international.
Yeah, we've gone international. Yeah. We were also invited to speak to the UK bladder cancer charity, which is really big. It's like huge in the world. And they asked us what we doing, because they don't get it. They only get like 10 people that come to their online groups. And they said, well, what do you guys do to get 40 people in your group? So they came to us for advice, which we were so chuffed about. Yeah.
Become the consultant in this area.
Yeah, we've become like world experts. So it's just amazing how doors open up, but you've got to take that step, that first step, that active interest. You've got to be interested. And when you do, it's just, the world's your stage.
Speaking of stages, we heard that apparently you have a drama project that you're passionate about. Could you tell us about that?
Yeah, that was a good segue.
Yeah,
Well
that was
done.
a very impressive segue.
I think I set you up pretty good there.
I think you did.
That was a clearly planned maneuver.
Yeah. So on top of all the things I've done in my life, one of them was speech and drama. I did my exams, my Trinity College exams. You may have heard of that if you do piano or music.
The average med student side quest.
Yeah. So
Did you do piano?
I did not do piano. I was a clarinet person.
Oh, I did piano.
Yeah.
Oh, yeah.
Did you do piano?
No,
Spencer?
I didn't. I've always wanted to play the piano. It's the one thing that I haven't done.
The one thing missing on your resume.
You're the one thing. I've done everything else except play the piano. Well, I will get to it one day. But no, I did speech and drama through Trinity College. And I did my teacher's diploma, and while I was studying medicine, and I thought, as we all do, right?
As you do.
We're all
Yeah,
overachievers.
Of course. Who doesn't do 2 degrees at once?
Right? Yeah, because I actually ended up doing the next stage past the diploma. So it's like a licentiate, they call it, where I had to do a thesis. And I actually looked at the human body in speech and drama. Anyway, and then I shelved it. You know, life got busy. Kind of had to do medicine, treat patients, and do surgery.
That was just actually just a side quest. Yeah,
Right.
I completed that now.
Actually, I always used to say I studied drama and theatre and did medicine on the side. No, not really. I had to, focus on medicine, and I missed it. You know, you long for that, but I also always dreamt and thought about how the two could be married together, because they kind of are. You know, it's actually the art of medicine, not really the science of medicine. So there's art in there, and now it's a big movement, humanities in medicine, and there's working groups and there's societies and there's journals, and it's pretty big. Anyway, during my conference last year on a medical education, the go-to conference in Europe is the AMI conference. And I know some medical students do attend. And one of the workshops was on using drama in medical education and teaching. And there was a guy from Europe who is doing just that. And it's actually sort of part of their curriculum. And he's not drama trained himself, but he's collaborated with the drama team and brought it in. And so that really got me going again, and thought, how can I do this? Because I've always wanted to, and I thought,
and you're qualified.
Yeah, and I'm qualified. That's right. So I thought, well, let's do something experimental, and so I just started it on the side as a sort of pilot project, if you will. And I think it's gained a bit of traction, and so
it's gained quite a lot of traction.
Yeah. And so it's once a week. And sort of after hours, obviously, you guys are busy. And it's just a time, I always say I take my academic hat off, my doctor hat off. Don't see me, I'm not here in that role. We're here to have fun, go back to being a child, and, it should be about play and fun and just letting your imagination sort of free and being allowed to express yourself as and how you want to, because medicine doesn't allow us to do that. It's quite formal, isn't it? And there's no real room for that. And so I thought, well, this is a great way to do that. But also, it's a safe space. It's a good place to experiment. It's a good place to make mistakes. Again, something we're told we can't do.
It's very scary to just do anything wrong in medicine.
Right, and rightfully so, I suppose.
Yeah. Oh yeah.
Yeah, we do learn from mistakes, but someone always says you don't also want to bury your mistakes. But going back to this, the class is an option for you to safely make mistakes in communication. Say the wrong thing. What will happen? How will the person respond if you say something wrong? No one's going to be hurt because it's not real. Yeah, and so I try and bring a few themes related to medicine, but I also want it to be a fun time and just for people to take a healthy distraction, bit of self-care. Yeah,
and I think we discussed this before as well. It's just like throughout medicine, it's always there's so many things we can do wrong that we don't often have a place where we can kind of explore and discover more things about how we communicate, because most of the time, for most medical students, either we're talking with our friends about medicine, or it's an OSCE patient, or it's a real patient. And communication in that kind of environment can often be very structured, very rigorous, and you don't have a lot of freedom to kind of explore the ways of communication, which a drama class is almost purpose built for.
Exactly. But and the other thing is, I don't think we take enough time on the self-care theme to think about ourselves and who we are as people and what our emotions are. And if you don't get in touch with that, it really can influence your interaction with patients. If you don't deal with or understand how you are and where your mental state is at, how you respond to other people, it could be very hard to do that in the real life. And so that's why it's another benefit. I mean, there's tons of benefits. I can go on for this forever, boundaries and, physical movement and touch. And I mean, the list is endless as to how and what you can do, being flexible, spontaneous, which we do through the improvisation, walking in the shoes of your patients, the whole empathy, so characterization, doing all of those exercises, really, really getting into the role of being a patient. What is their life like on all the different levels? So it has that power. Yeah.
It sounds like your journey in medicine has certainly been a very varied but also exciting one. From all of your experiences across so many fields, what do you think is the most important thing for medical students to know?
Yeah, that's, wow, as you said, with so many experiences, how do we sum this up? Look, I think the important thing is focus on your studies, not to lose focus. That's why you're here. That's what you're here for, first and foremost, and there were times where it's easy to get distracted or focus too much away from it. This is always going to be your priority. We were lucky to get into medicine. It's not the easiest thing to get into. Someone saw us, someone recognized us and knew we could do this. So we've got to take that opportunity and make the most of it, right? So that's always priority number one. Everything else you can work around. There's enough hours in a day to get things done. You can, if you manage your time appropriately. Believe you me, you can do so much if you manage your time. Also, a can-do attitude is really good to have. You know, you can do it. Don't limit yourself and block it. We can all do these things if we want to, and we allow ourselves and we believe in ourselves. And if you want to make a change and in something, you don't believe in something, then do it. Don't be a bystander. Don't sit back. You know, don't be like, oh, someone else will do it. No one else is going to do it. Only you can do it. Yeah. So if you believe in something strongly, you stand up for it and you go and do it. You just take the plunge. It will be scary at first, but you just go. And very often it's being in the right place at the right time that opens up doors and leads you to opportunities. And very often it's a case of, well, no one else did it. You're the only one for the job. You're gonna become this person. You're gonna be the go-to, the well-known, the advocate. So yeah, just do it. Yeah, and look for opportunities, and use every time and moment that you have in a hospital session, whenever you're in the hospital, to be with patients. Speak to them, practice your skills, as you said. Go to theatre, go and watch operations, ask questions. You know, no one's going to run after you in a hospital. They don't, especially when we're busy in surgery and that. The onus is on you to step forward and say, I'm a medical student. These are my needs. This is what I'm here for. How can you help me? And it's a give-take thing. Yeah, it's got to be help the surgeon, carry their bag if you need to, you know, offer to go and drop off a specimen, you know, offer to help with some data collection, offer to go and get some patient information for a meeting, go and find journal articles or present something. Well, that would be amazing. Medical students presenting at the journal club, what is this, you know? Know that you belong you're there, you belong in the hospital. It's your place. Paid a lot of money to get there, right? So you have the power and you must use it to its full potential.
Yeah, that's really interesting. I remember one of the things that kind of really gave me the confidence to like be active within the hospital is one of the older students said to me one day, and they were like, "You're the only person in the hospital that paid to be there." You're the only person. Everybody else is getting paid to be there. You're the only person who pays to be there.
100%.
So you have every right to be in the hospital. You have every right to do whatever you are capable of doing, because you were the only person in the hospital that paid to be there, including and also the nursing students as well.
Doesn't it just make sense? Yeah. It makes total sense. But of course you're not going to be arrogant to me like I own the place.
Yeah.
No, that's why I say it's a give take and help. And the hospital's all about teamwork, and you scratch my back, I'll scratch yours. You know, that's how it is. And so if you show interest, you're prepared for sessions, you've read up, you know who the cases are on the ward, and you've read up before you arrive, you know, that it shows interest. It shows you care and you want to know more, and so they'll teach you more. If you show you want to know more, I guarantee you they will, because we all want to pass on our knowledge. We all want we want to see the best for you. We want you to be the best doctors. You know, we can see ourselves in you where we were there one day, and so we want the best for you. So we're going to help you. But you've got to also come to the party and show that you're going to walk along that journey with us.
Well, thank you so much, Dr. Spencer, for coming on today. It's been an absolute pleasure to chat to you. If any students do want to get involved in your drama group, are you happy for them to contact you?
Sure. Yeah, why not? I guess the more the merrier.
Well, hopefully after this episode, a lot of people are knocking on your door coming to your drama group, because it sounds like a great initiative.
Yeah, thank you. Thank you so much. And thanks for hosting me on this podcast. I think you're doing a really great job.
Oh, thank you.
Yay.
All right, thank you.
I better do one as well.
Oh my God, yes. Thank you so much. And that is mostly it. See you, everyone.